I believe something that you deal with frequently are are plaques in the carotid arteries
Yes, we do.
going to
We
the
do.
brain. Now, why are
Yeah.
those called endarterectomies? Why aren't they called carotid atherectomy? So we could tell me about the name. Well, why is that? How common is it, and what can you do about it?
Okay, so carotid atherosclerosis of the major internal carotid artery is something that's been described for a long, long time, and I'm not going to bore you with all the history of it, but I will tell you that when we see patients who present with a symptomatic lesion of the carotid artery that has caused a stroke,
Okay.
or maybe and a stroke is defined as a neurologic deficit that persists beyond 24 hours, or maybe a mini stroke or a transient ischemic attack, a TIA, which is
Okay.
less than 24-hour duration of a neurologic problem. When we see that and we have a very significant blockage or lesion in the carotid artery, then we know more oftentimes than not that the risks are going to be less if we can go in and clean that blockage out than if we don't do anything and just treat that patient medically. Now, I, it's a huge, huge oversimplification. I have probably 4 textbooks on my shelf that are just about the carotid artery.
Wow.
So it's really one of those things that it's a lifelong learning process. And since I've been in vascular surgery, this is my 28th year. I've seen a dramatic change in the way that we treat patients. For example, asymptomatic carotid lesions, even up to 70%, 75%. We're by and large treating those conservatively with medical management now rather than surgery or stents.
Okay.
If you're symptomatic, if you've had a little mini stroke or a stroke
Right.
and you have a significant blockage, and significant in my mind would be 60, 70, 80%, then we're going to either put a stent in that or clean that out. And again, huge oversimplification, but it's one of those things that we could talk for days about this and
Yeah,
still not even scratch the surface.
it's a big subject, and it seems that that's one of the hot spots. You mentioned there's certain areas of the body that tend to make these plaques.
Yes,
And it's a hot spot for some
it
reason.
is the very start of the carotid, the internal carotid artery that goes up to the brain, is what's called the carotid bulb, and it's a little dilated area of the artery, and it's the posterior lateral surface that tends to accumulate plaque. And the reason for that is probably because there's normally a reversal of flow there, and that reversal of flow exerts a hemodynamic injury to the endothelium.
A turbulent is rubbing it. It's
Yes, the
rubbing it with a
turbulent
turbulent.
flow, and it allows the migration of LDL across that injured endothelium, which becomes oxidized and leads to this whole process that we deem atherosclerosis. Atherosclerosis is really an inflammatory process. I think pretty much everybody agrees on that. And it's due to the oxidation of the LDL. And it tends to happen right there in the carotid bulb because of the physical properties of that area and because of a lot of the hemodynamic properties in the face of hypertension, in the face of high cholesterol levels, nicotine, things like that.
Or homocysteine, and I'm gonna push back on the
Yes,
cholesterol
yeah, I don't want to get
and
into that.
and intimal thickening and migration of macrophages that it might be more important than the cholesterol
You're
itself. And anyway, so once again, huge topic. But what I'm interested in is how do you go in there, Johnny? Peel out this eggshell crunchy stuff, get it out, and then put it back together. And I just imagine all these crumbly pieces. Once you do it, all of them just you open up the artery and it just goes up to the brain and strokes out the brain. How can you do it so cleanly and effectively that you're not showering the brain with more of these?
well.
Because atherosclerosis people need to realize these plaques are like crunchy eggshells.
They come in all different varieties, from crunchy
Ah,
eggshells to cottage cheese consistency, et cetera, et cetera.
toothpaste. I've seen toothpaste.
So almost always when we are working on the carotid artery, we have it clamped so that there's no flow going to the brain through the part we're working on to flush those particles up to the
It
brain.
seems that clamping would break
Aha.
off pieces.
Yeah, that's very good. So we use a shunt. A lot of times we will use a shunt around that area to maintain flow to the brain while we're working on that artery.
So you can plug in one side and the other,
Yes.
and
Yes.
temporarily bypass that spot.
And
Ah,
there are times where we don't use a shunt because we know that the collateral blood flow in the brain through a system that's called the Circle of Willis.
so blood flow from the other side is enough to keep the brain alive while you're working there.
The back and the other side, yes. And we're
Right.
able to measure certain factors before we clamp. We're able to measure certain pressure points and determine, is it adequate or is it not adequate? And if it's not adequate, we're probably going to use a shunt. If it's adequate, then we probably do not need to use
You've
a
got
shunt.
time to do your work.
Yes. There are surgeons who, if you're going to do this open carotid surgery, they will use a shunt all the time. There are surgeons who will selectively shunt. And then there are surgeons who, I don't ever shunt, I just do it really fast.
Real fast. And
Yeah,
they're good
yeah,
at that.
yeah.
And they can do that.
And those are the open operations. If we're doing a stent, then almost always we will have a protection device to keep the little particles from going to the brain. And that could be an umbrella filter placed up high.
And
So
does that stay there forever or just during the case?
Just during the case.
Okay.
We take that out at the end of the case. Or we can reverse the blood flow so that the blood flow is not going up to the brain, but it's actually being reversed into a little protection device.
And you're washing out those pieces.
Yes.
There you go. Because that always bothered me. How could you do that without creating strokes? Clearly, you have methods for doing that. Fascinating. So you do a number of those. That's a fairly common procedure for you, isn't it?
It is very common to do a carotid endarterectomy. And endarterectomy means taking out the inner lining of the artery.
Okay.
The artery is made up of 3 different layers, and we take out usually the intima and the media where the plaque resides.
Okay.
The adventitia is the outermost layer, and fortunately for us, it's the strongest layer, so we can take out the inner 2 layers without compromising the strength of the artery.
Now, how come clots don't form over this rough surface that you've created?
Well, we use a blood thinner during surgery to prevent that, and then usually after surgery, we will use a platelet inhibitor like aspirin or like Plavix or like something like that to try to keep that from happening. But the other answer to your question is we try as best we can to make sure we have a smooth surface and we do not have many irregularities there, many if any, so that the flow is nice and smooth and laminar and is not turbulent in any way.
You've got to be what's the size of the suture? Now this is kind of esoteric. Your sutures are getting small when they get down to 6, 7, 6.
Yeah, we use 6.0
6.0
and 7.0 for the carotid.
You're getting down to close to hair, to several times bigger than a human hair at that point. And then you're using very smooth sutures called Proline, I believe.
Yes. We use a monofilament Proline suture, and blood elements stick to that much less so than, say, a braided suture, and that's why we're using the monofilament. We use what's called loops, and loops are glasses that have little telescopes on them.
So you're doing this under magnification?
2.5 magnification minimum, sometimes 3.5. And that helps remarkably. The sutures really need to be placed in a precise fashion, and that's what your 5 years of general surgery and your 2 years of vascular surgery is all about. And then obviously the learning that goes on continually once you're out in practice.
This is why having an experienced vascular surgeon is so important.